Can we get vulnerable for a second? Do you feel awkward talking about a patient's weight? Like you should talk about it, but aren't really sure when and how? And you definitely don't want to offend or shame the patient, but you know they really need to make some changes to their health. If this is you, you're in the right place, my friend. In today's episode, I'm sitting down with Nina, a registered dietitian and PhD health psychologist, and we're diving into this very topic: how to address patients' weight in a way that's not just compassionate, but also effective. And this is the tension we must balance as providers, wanting to share life-saving information, but in a way that shows we truly care about the patient. The late Timothy Keller once said, "Love without truth is sentimentality. It supports and affirms us, but keeps us in denial about our flaws. Truth without love is harshness. It gives us information, but in such a way that we cannot really hear it." I'm Colleen Sloan, a registered dietitian, PA, and your nutrition mentor. Welcome to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. We're going to talk about everything from knowing when to bring up the topic of weight to really digging into what motivates your patients from the inside out. And it's not just about the numbers on the scale or their BMI. We're going way beyond that. And here's the best part. We're diving into practical strategies that really work. These aren't just effective, they're also designed to help you prevent burnout. Now, I know what you might be thinking. Colleen, this sounds amazing, but I only have 10 minutes with my patient. If I'm lucky, how can I make this work? Well, I am here to challenge that. I asked Nina for simple, actionable tips that you can use in just 2 minutes. Yep, it is totally doable. And trust me, you won't want to miss a single second of this episode. So grab your coffee, get settled in, and let me introduce you to Nina. Nina is a registered dietitian and PhD health psychologist. After leading the Medical University of South Carolina's Metabolic Bariatric Surgery program, she has joined SECA's Medical Body Composition and Bioimpedance Analysis Division as the Professional Affiliations and Education Manager, working with healthcare professionals to advocate for using body composition outcomes for better patient-centered care. She's an advocate for effective communication, people-first language, and patient-centered approach for people with obesity. Nina, thank you so much for being here. Thanks for the gift of your time. Welcome to the show.
Thanks. I'm so excited to be here. I feel like we're so aligned in a lot of the things we post and talk about. So I think it'll be a good conversation.
Oh, yes, I cannot agree more. So I want to jump right in because the first question that I have for you is an important one, and it's exactly where clinicians start. And it makes us feel uncomfortable in the exam room to even bring weight up. So I'm curious, should a provider even bring up the patient's weight at all during a visit?
So I think that the big balance here is kind of balancing what the patient expects from you and then honoring kind of their individual experience. So you've got to consider that people coming in have a whole long history before they're walking into your room. They've tried so many different things. And so I think really that no assumptions piece is really important, and not to assume you know where they are. For me, I always remember a patient that I had when I was working in bariatric surgery who I assumed that she knew nothing about nutrition. And I started right at the beginning and talked to her about, everything really basic, and then found out halfway through, and I took a breath, this is years ago, that she's a dietitian. And so I was super embarrassed of, knowledge is not her issue. It's really implementation and application. And so I could have saved all those words and basic information and really dove in. So to me, I always come back to that story and that patient and thinking about, really sort of starting from curiosity approach of where they're at. And so I think the conversation about weight is really important to have in the way that works for the patient. So, you may be asking, I think, permission, would it be okay if we discuss weight? I think that's a really good, easy, simple, memorable question. It's not an offensive way to ask that. I think that's a really good start. I also think it's a way to connect for whatever you're there for, to connect to your health. So, you've mentioned a bunch of symptoms, fatigue, your knees hurting. Those may be related to excess weight. Would you like to talk about this to see if we can, kind of help you feel better or come up with a plan about it? But I also think we need to balance that with the patients who need their provider to bring that up, expect their provider to bring it up. And we also know that people may need to hear it from several providers before they're actually able to get into action and it's more connected with what they're able to do. So I think permission, health conversations is appropriate. And I think giving them that opportunity to have the autonomy to say, no, that's not what I'm here to talk about.
Hey, we'll get back to the episode in just a minute, but I wanted to tell you about a resource I made for busy clinicians like you. Between back-to-back appointments, endless charting, and constant patient demands, you barely have a moment to breathe, let alone spend 15 minutes on nutrition counseling. You're under pressure to give advice quickly, but when patients don't follow through, it feels like the whole conversation was pointless, and you feel frustrated. Wouldn't it be nice if you had a framework to follow when giving nutrition advice? That's why I created the Behavior Change Toolkit, your go-to resource for turning quick conversations into powerful, lasting results. It's not just another set of guidelines or a 3-hour course. It's a system. These are the exact steps that I use with my patients. I've refined the process, and I'll show you how to translate nutrition information into action in under 7 minutes. This digital toolkit is packed with everything you need to guide your patients toward better health. We're talking scripts that make tough conversations easier, templates that boost your confidence, and a customizable patient workbook they can use at home. Imagine confidently discussing nutrition with every patient, knowing you've got the right tools to spark change without adding time to your visits. Go to examroomnutrition.com/toolkit and get your behavior change toolkit today. That's examroomnutrition.com/toolkit. All right, let's get back to the episode. Nina, I love how you started with asking permission. I talk about this so often, and honestly, it can be done in pediatrics as well, too. I start doing this when a child is probably 8 years old, and I will just turn to them and say, hey, are you comfortable if we talk about your weight? Or is it okay if I show you your growth chart so we can see how you've grown over the last year? And I actually had a mom say, I'm really glad that you asked that. No one's ever asked us that before. And I think it's such an important piece of patient care to put that autonomy on them because it is their body and it's their visit. And I think that's such an important place to start. I've heard so many times from just friends of mine that, they might go to the doctor because they fell and they're worried that their wrist is broken. So they have wrist pain. And the clinician, the first thing that they come into the room is like, oh, well, let's talk about your weight. And they're sitting here like, I'm not here because of that. I'm here because I hurt my wrist. So in your opinion, is there an appropriate time to do this at a certain visit and or time during the visit? Should it be set up front? Should we wait until we catch a vibe on how it's going? What are your thoughts on that?
Well, I think it really is a nuanced topic and, it really has a lot to do with that provider experience. I think some of this conversation, I always think of our evidence-based practice, right? And we're always looking for guidelines and the research and the data to tell us, here's what you should do. But the other two components of evidence-based practice, to me, that are probably even more important are the provider experience and the patient values. So I think it's important to develop rapport with the patient for all the reasons that they're there for. And so that may be as part of an initial assessment. I'm also, I think we'll talk about this in a little bit, but as we talk about ways to assess patients' health long-term, I think there are some things that should be part of annual assessments where we look at, other metrics other than just weight. I don't think jumping in with a brand new patient right off the bat, unless that's what they're there to see. And so I'm assuming we're talking about clinical staff that have a variety of things that they're seeing patients about versus if you're in a specific, obesity care clinic of some sort where that's what they're there to talk about. And even still, I think the language and communication is important there to do that in a way that's not, well, here's what your ideal weight is. Like, that's what we're going to get you to.
I love that you went there, that we are looking towards outcomes beyond weight and BMI, because that is my next question. We are finally and slowly moving away from outcomes only following BMI and weight ranges. But yet those numbers are still used for billing and coding and some approval of certain treatments. So I actually have patients call and ask me very often, if we're not using BMI and it's not the only indicator, why is it on my super bill? Why is it as part of my child's diagnosis? So I would love for you to kind of walk me through, how can we explain that BMI to the patient and why we're still actually using it, even though, we're moving away from measuring it as a sole outcome.
I think that is perfect because that's where we're at right now. And I've been in the, bariatric field for 18 years now. And so for a long time, it's just was sort of something we all accepted. And, we didn't love it, but this was all we had. And so I think it's really exciting that we're finally at this time of, okay, the AMA is coming out and saying, hey, this is not, there's a lot of stuff in this history that's not great and we don't love it. It's not the greatest for the individual. But beyond that, I think we're close to really seeing people put the next steps there of, well, then what do we use? And so, I think there's a lot of ways we can get to more individualized approaches that actually do work for the individual. The way I sort of frame and talk about BMI is really, hey, this is a screening measure that helps us determine how much excess weight you're carrying. BMI is really just a relationship between height and weight. So it is used when we need something free. It's used when we need, epidemiologic studies where we're looking at a greater population, because it kind of gives us an orientation of where someone's at. It's not a specific measure of excess body fat or, importantly, who you are as a person. And so I think even in your limited time that you have with a patient, it's worth a sentence or two on that topic to really let them know, here's where you stand, here's what's happening in the field, and let them know, hey, now that we have better measures, we're going to do better. And so I think people really understand that example of, you could be a bodybuilder and have obesity, but would anyone call that person as someone who has excess adiposity? No. You could be a frail older person and, be considered normal, but you're, at risk for falls because you have sarcopenia. And so I think if you sometimes using those extreme examples is a good kind of counseling strategy to say, this is why this is not a great measure. And you may be somewhere in between that, but we want to know your individual risk. And so here's what we're going to do to determine that. So it may be blood work. It may be looking at health conditions, getting on or off medications. It may be waist circumference. And, in my world now, it's body composition. And so I've been very happy to see the uptake of that, where people are actually saying, okay, hey, your weight may be here. Even your body fat may be here. Excess adiposity, of course, is the disease risk that we're talking about. But I've been happy to see how much people are talking about muscle mass and preserving that as we age. And so I think these are some of the better metrics that we're going to see come up as suggestions, maybe from the AMA. That would be great. But just in general, as part of our clinical practice guidelines of, okay, this is not it, but here's what we do recommend.
Now, I want to linger here a little bit. And you mentioned a few kind of non-scale things that we can measure for outcome. And I'm curious as to what other things, because there are plenty now, and some things that clinicians probably aren't thinking of that we can measure that are non-scale victories that we can suggest that we follow and that the patient actually focus on more than just losing weight. So I would love to hear some other non-scale victories that clinicians might suggest and throw out there to see if that might encourage the patient to track that.
Yeah, so there's a lot of non-scale victories. My first actual suggestion would be not just to list them and sort of jump into advice giving maybe, but it would actually be to sort of have that conversation about what matters to you. And I think that's one of the most important kind of questions, however you feel comfortable phrasing it. But when you can get to the core values of a patient and really start to see what they care about, what's their identity, that's not only going to be helpful for setting goals, but it's really going to be helpful for keeping them on track long term, because we all can get excited about a short term thing. A lot of the goals that people set tend to be these sort of short term objective things that are somebody else's idea, extrinsic motivation type options, but really the intrinsic motivation, that someone's internal core beliefs, that's what's going to relate to them. So that would be the non-scale victories that matter. So you may hear in their language, they're talking about energy. I think that's a big one of how do you feel? And there's some people who can really connect to energy levels, sleep quality, and things like that, happiness, enjoyment, mood. And then there's some, I'm thinking of my more typical male patients who are very numbers focused. And so for them, their personality or their preferences may be more objective, but in different ways. So they may be the ones who want to get different blood work tests that they can do. There's more innovations, I think, even in looking at liver fat that you can do that are objective scores and numbers. I really like looking at visceral adipose tissue. It's an objective clinical measure, but it's something that's actually directly related to health. The fat around your abdominal area, rather than just the weight or something like that. And then I think, ability to do things you couldn't do before, coping and emotional awareness. These are all important for the right patient. Social things like relationships with others, connections in their life. And so those are some of the non-scale victories. There's things even like clothing size, which sometimes can be a proxy for weight, but for the right person, fitting into certain clothing can be a goal that they're looking for. And then the functional stuff, which I think most everybody can find something like, I want to get on the floor and play with my grandkids. That was such a big one for a lot of my patients. Flying in an airplane and not feeling uncomfortable as you walk down the aisle and someone looking like, oh no, are they going to sit with me? So some of those, and you can kind of gather those from the way that patients are talking about how they feel about their current state. And then when they start to talk about where they want to be.
Those were so inspiring, to be honest. And I love how you started out without just listing things that, hey, you could choose one of these, but that intrinsic motivation is so important. So it is so easy to just say, well, what matters to you? What's important for you to improve upon, and how can I help you get there? I think that is such a great collaborative approach that clinicians need to start focusing on more than just being prescriptive and just saying, here, do this, follow this.
It is so easy, and everybody has that. You don't have to remember it. You just have to be curious, and you just have to be able to take what they say and then work with that. So not just say, okay, that matters to you, but here's the handout and here's what we're going to have you work on. Because I also can connect this so closely to burnout from providers, right? So people get sick of, I tell people the same thing and you can only lead a horse to water. It's like, okay, your patient's not changing behavior. You're saying the same things. Like, clearly it's not their issue. This is yours. You've got to switch up your counseling and try to connect with them in a different way. And their long-term goals might sound weird or odd or unusual to you, but it doesn't matter, because they're going to work on them if it matters to them, not if it's just your goal for them.
I think that's a really good point to mention, that taking this approach as opposed to just handing them a handout leads to less burnout, because I never thought of it that way, but you're so right. Like, it is exhausting trying to get people to change, and then they come back and they never change. And you're like, I don't know, I've been given all this information, but they're still at the same body size, or their labs haven't decreased at all. And it's exhausting as a clinician to just feel like your wheels are spinning and you're not really helping patients. And that's your goal as a clinician. That's why you went into medicine, is to help people,
Right.
So I can see how that definitely leads to burnout. So I think that's a really great point, Nina, that you made, that I had never even thought about.
And it's connected back to, as I say, that evidence-based practice model, right? That we're all taught, we all say it. It's kind of a buzzword where you see people say evidence-based, but I think people really focus too much on research and data, really. And they're forgetting that, the component that we're really talking about with behavior change for the long term is that awareness doesn't equal action. Education doesn't equal motivation, and information doesn't equal behavior change. And I do love that about counseling and motivational interviewing and some of that, where you can really figure out what matters to the person and then kind of help them get where they want to be. And then it's also good because you don't have to know everything. You just have to have these couple clinical questions that we can actually ask to inspire the right kind of conversations, because you don't have to know the detailed information. You just have to know human behavior.
It's so true. And I love that you pointed out kind of the fallacy that we believe about information, that if we give the patient this handout and if we tell them the statistics of, obesity leads to this many deaths and this many chronic diseases are connected with a person with a higher body weight, we think that that's going to change them. As a clinician, you're kind of taught that you need to educate patients. but it doesn't, right? We know that. So I would love to hear from you. How can we provide information? Because information is important, but without being pushy and judgmental and helping kind of guide our patients towards behavior change.
Yeah. So, I mean, there's lots of behavioral approaches. Counseling, I think, is way more appropriate here than education for the most part. It makes me think when I started as a dietitian in bariatric surgery, I really thought it was going to be about learn this diet, teach them this diet. They would follow it because they just had surgery. They'd have to be so motivated and they'll do whatever they're supposed to do to make it work. And then I would be happy. And so it was, a few months even into that role where I realized that I did not have, from my background as a, regular internship dietitian, I did not have the background to really help with actual behavior change. So not that I recommend everyone get a PhD in psychology because now they have coaching programs that are really great. But I think attention to that skill set is something that we all, and not just dietitians, but any clinician really should be focusing on. How do you help facilitate someone to change their behavior? And it's a lot different than just, like you said, throwing a handout, giving them information. So this is really where, we've got to kind of figure out where they're at from a stage of change perspective, what motivates them. Do they want to change? There's plenty of patients that will just continue to show up in your clinic because they're a rule follower and no change is being made in between because you haven't connected with them, right? And maybe there are people who really do want that handout and they're going to go home and follow it. In my experience, that's not the majority. And figuring out what that thing is for the person is really key. So I am a big fan of using some of the motivational interviewing approaches. If the person's kind of on the fence, if they're ambivalent about change, you can hear in their language, well, I really like to do this, but I find myself always doing that. That's kind of, they're doing that either or. You can sort of even picture that scale in their mind. One of the best tools I love from motivational interviewing is that decisional balance. A super easy tool. I've done it on a bar napkin with a friend. You really divide it in 4 and talk about what are the pros and the cons of changing and what are the pros and the cons of staying the same. And when you can get them to talk in those 4 quadrants, you'll start to hear change talk. And change talk sounds like, oh, well, I guess I could really do that. Or, oh, well, yeah, I did say I wanted to do this fitness goal, but I'm really not making any moves towards that. You're sort of hearing them say, I want this, but I'm stuck. That's when you can start to sort of, work on the next part, which is, okay, so I'm hearing you say you want something different for yourself. And, maybe is this a good time? I've got some information about that. Would this be a good time to review that with you? So it's, again, that kind of permission, neutral information. Or another tool in that regard, I think that's helpful is, there's a lot of information about this. I want to know kind of where you're at. What do you know about that? So kind of elicit their understanding of the topic before you provide neutrally that information, and then elicit again. Well, how does that sound? Where do you stand with that? Again, thinking back to my patient who knew a ton about nutrition. If I had done that simple step and said, well, hey, what do you know about that? Well, I did 10 years of this and I've taught this, but my problem is sometimes people will say it like that, where I'm feeling stuck. And then you can kind of get them to that next place. And when you can just make that connection between here's where you are, here's where you're saying you want to be. And you sometimes have to be quiet. That's hard for me, but I've learned to be a really good listener and really sort of say, oh, interesting. You want this and you're here at the same time. Our brains don't like to have that cognitive dissonance where you're doing 2 different things. So we want our thoughts and our actions to align. And so you may be able to, with some silence, even get them to say, oh, yeah, that does sound like, talking out of both sides of my mouth, or however they might phrase it. And then, well, I guess I could start to, and then they fill it in. So I think that's a really good approach to take. Again, it's based out of curiosity. It's based out of, understanding that behavior change doesn't just happen because we think we have a problem. I also think it's helpful to phrase it in the way you would think about a behavior change that's kind of completely out of health and nutrition. So sometimes smoking, that's a pretty black and white one for some people, but motivational interviewing was, I think founded in that literature. But if you talk about smoking to someone who came to you to talk about, their weight or health or eating, it's easier to see that. Just like it is like you've got a family member who's got a problem. Well, you know the solution to their problem, right? If they only just did this, you can get them to sort of practice that talking as it relates to something neutral or non-nutrition related. And then you can kind of make that tie back to, oh, well, let's apply that same kind of thinking to your situation here. Oh, well, there are some parallels. And then, so I think that's kind of a nice way to do that. Different strategies too. And I think another big piece here is really connecting to core values and who people view themselves as a person. So you can there's even values inventories you can look at. There's ways that you can say, what are your values? If family is a big value for them, you can kind of pull back and say, and frame some of the stuff that they're saying as it relates to family or as it relates to achievement or, whatever that may be. Again, figuring out what their values are and then connecting it to them. That is the long-term change. I mean, I also would like to say people can make short-term changes. So when people want to argue or talk about, well, so-and-so did this and they lost this amount of weight or whatever it is that they're saying, sure, there's things that can help anybody achieve these kind of goals, right? But are you willing to do that long term? Do you see yourself doing that in 10 years? Probably not. So let's work on something that you can be okay with. And then your self and your values and your new behaviors all line up, and then that sticks.
I really love, Nina, how you always bring it back to the patient. What are their desires? What are their values? What are their goals? Not the provider putting their own goals and outcomes onto the patient, because it makes our job much easier. And it also builds that connection between patient and provider. And you're so right. When you went back to, one of your patients was a dietitian. I actually think patients know more about diet and nutrition than most medical providers, excluding dietitians. But they've lived this stuff, right? If you are trying to lose weight and you have maybe struggled with your weight for 10, 15, 20 years, I bet money that they have spent hours through YouTube and literature and reading on all these different diets and actually following all these different diets. So they probably know way more about the diet than you as the provider sitting in front of them. So I love that you always just bring it back to asking questions and asking the patient, like, what do you know about this? What do you need from me? What are your goals? What do you wish to do? And I think that brings us nicely to continuing the conversation of those amazing practical tips that you had suggested of how we can help our patients kind of understand where they're at and where that disagreement is between what they want and what they're actually doing. And as a clinician, it's so hard to offer suggestions. We're told to offer individualized approach to nutrition. But when we have 10 minutes and as the provider, you're dealing with medication refills and referrals and all their other medical concerns, you have maybe 2 minutes left over for nutrition in reality. So what other kind of actionable things and strategies can we offer to the patient? And to just give, let them leave with a nutrition nugget, and then they can come back to us with maybe, more information, or that we can have like a longer visit with them.
I think one of the best strategies or questions you can ask is sometimes to just, again, acknowledge, hey, we only get 15 minutes. I would love to have an hour with you. I would love to sit down and really kind of get into your history. But knowing that, my expectation is that we're going to have several meetings over the course of years together to sift through that. What is like one thing that you came here to talk about today that I can, answer for you so that you feel like you've got something to work on? So again, acknowledging that it's nuanced, it's complicated. I think that's important because you're really walking this tight line between 2 minutes. That's not enough. You don't want to give the simplified information because sometimes that's more harmful than not. And you're getting into a situation where, at the end of the day, like my provider just said, eat less, exercise more. Thanks. Like I didn't know that. Right. So you want to acknowledge that 2 minutes isn't enough, but you want them to go away with something important. And so I think that can help them rise to the top and prioritize what they want from you. That gives you good information. But again, you've got to come up with something that is important to them. So I think in a short period of time, talking to them about what is something that you think you can do, what is something you want to do that, you could see yourself doing for the long term. And that can sort of, get them to that goal setting conversation. So again, I think acknowledging that hey, this is hard work. I'm here telling you, hey, you should try this way of eating or whatever, but I'm not the one who has to do it. So, how do we reconcile that you've got to go home and do this? And then I think, that the last thing would be individualized approach and assessment. We're hearing a lot more about that, but that really is, to me, personal metrics and personal data points. So what are their health conditions that they're either have that they're wanting to reduce, that they are at risk for because of their individual profile or genetics or family history? And what are their numbers? So whether that be blood work, in my world now, it's body composition assessment. So it's looking at, hey, where did you start when we started meeting together with your body fat? That's looking at your adiposity. Where did you start with your muscle mass? And people like that kind of data because it shows them where they're at. And you can tell people all day long, I think sometimes eat less, exercise more has turned into eat more protein, do some strength training. That's a blanket recommendation. It's very simple to say that. I don't think that connects all the time with actual behavior change. I heard someone said one size fits one. I think that's a good way to put that.
Now, for my last question, I'm going to play devil's advocate here because I know not everyone listening to my podcast will agree kind of with what we're talking about not focusing as much on weight because, we know that obesity is one of those conditions that leads to chronic diseases and death. So I know you're aware of the Health at Every Size movement, and I love that it's seeking to decrease weight stigma. However, and here's the devil's advocate side, as we're moving away from weight being an outcome or a measure, are we saying that their weight does not impact their risk of chronic disease and death?
So this is a topic that I think we've put in this black and white, all or nothing. This is what our brains tend to do. We want there to be a clean cut. But I think that what we all can agree on is that the weight bias is harmful to people. And I think we also should all be able to agree on that patient-centered approach and listening to someone's concerns. So I get concerned when I hear a provider only practicing out of one camp, where that, to me, that means they've pre-decided, you come to me, I'm going to do this type of approach to you. But I really think that we've got to think about those health conditions. And again, we're talking about health conditions, not just weight. So I agree, just having a high weight does not make someone, I would say it doesn't make someone have obesity and it doesn't make someone unhealthy, but it's these other risks, these individualized risks that may have more to do with their genetics, their ethnicity, their gender, and their own goals. And so I tend towards, let's figure out, again, as you've said, where the patient's at, what are they coming to you for help with, and how can you help them meet their goals? And so if their goal is to lose weight, I think that would be part of, helping them to do that in a way that helps those numbers, sets, good behavioral patterns up, and then balancing that with the mental health and the behavioral effects of part of that assessment should be looking at their history. Is focusing on weight loss going to be triggering for mental health and, disordered eating and all of that? I think we can all benefit from looking at the personal reasons that they're wanting to have that weight loss or not, and then looking at what you can do together and working on that together. But I would always, as you said, come back to the patient, come back to their story, come back to what they want out of this relationship and how can you help them?
So well said. And, treat the patient as a human, right? You're not treating their numbers, you're not treating their weight, you're treating them as another human. So I really believe that a little compassion goes a long way. So Nina, this has been so extremely informative and so helpful. I've just loved learning from you. I would love for you to share where people can find you on socials and just how they can connect with you.
Great. Well, yeah, I have become a new LinkedIn person. You can link to Nina Crowley on LinkedIn. And then through SICA, we have as a website, SICA MBCA. So that's SICA Medical Body Composition, that stands for. That's a good place to get our information.
Awesome. Well, I know I will have you back on again because I know my listeners will learn so much from you. And there's so many different topics about behavior change and discussing weight that we could dive into further. But for now, Nina, thank you so much for your time. I appreciate you being here.
I love that. Thank you so much.
All right, now it's time for my nutrition notes. Now, I want to revisit something Nina mentioned briefly, and that's how embracing a curiosity-driven approach in patient interactions not only enhances the care you provide, but also helps you avoid burnout. Raise your hand if you've ever experienced burnout. I think we all have. But by asking patients what they want to work on and where they're struggling, you're not burdened with the overwhelming task of solving every issue on your own. Instead, you're just guiding them in a way that feels manageable and engaging for both of you. This helps prevent the exhaustion that comes from trying to fix everything yourself and keeps the focus on what truly matters, supporting your patients in a way that aligns with their unique needs and values. So here's a quick tip for incorporating this into your practice. Start each patient encounter by asking, what is one area you'd like to focus on today, and how can I help you be successful in that? This simple question not only sets the stage for a patient-centered conversation, but also takes the pressure off you to have all the answers. Remember, it's not about having all the solutions right away. It's about working together and finding the path forward. This mindset shift can transform your patient interactions, making them more effective and less taxing. Keep this in mind with your patients today and let me know how it goes. Shoot me a DM on Instagram at Exam Room Nutrition. Well, thanks for hanging with me today. Until next time, let's continue to make our patients healthier, one exam room at a time. I'll see you next time.